So welcome everybody, and thank you for inviting me along this evening to come and talk to your group. What I'm going to talk about this evening is a little bit about vestibular physiotherapy and our role in helping people who have vestibular migraine and Meniere's disease. I'm going to talk a little bit about what vestibular migraine is. We'll delve a little bit into Meniere's, and at the end I'll touch on a couple of other conditions as well, just for your information. Now, here we go. So first of all, just thinking about the vestibular system. For those of you who don't know, balance is a complex response to many sensory inputs. So we get information about balance from three main systems. One is our vestibular system, so the input of the receptors in the labyrinth of the inner ear. And essentially these provide information about motion and the position of the head in space. One of our other important senses is vision, which gives us vertical references, perception of motion in the visual field. And then thirdly, our somatosensory input, which is essentially our muscles, our joints, and on the skin, which provides us again with information about position and motion in space, our interaction with different support surfaces, tension in the muscles, etc. And this is probably the most important sense. However, we know that the vestibular system also has a very important role and is often forgotten about. All of these inputs, all of these senses help to provide stability of vision, posture, and perceived body orientation. So they work together to achieve this. And this can be while stationary or while moving, and it all requires very good integration to give a clear picture. So when we think about the vestibular system, we think of the inner ear. And essentially its primary role is to detect a wide range of angular and linear accelerations of the head. It also detects changes in static head position with respect to gravity, and it's extremely sensitive and very, very fast. Now it has to be fast because it has to be able to detect and respond to challenges to balance within a fraction of a second. Otherwise, the person may have blurred vision, they may feel off balance, and they may fall. And essentially the information from the inner ear is then delivered to the brain to produce appropriate postural and eye movement responses to changes in head position. So if we look at this diagram here, what you'll see in the boxes in blue are the sensory systems, the ones I talked about earlier. So your vestibular system, your vision, and that somatosensory system. And they all feed into what we call the central part of the system, or the brain part of the system. And primarily the vestibular system goes into places called your vestibular nucleus and your cerebellum, essentially just areas in the brain. And then what they do is they help process information and help to refine and produce certain eye movements and keep us balanced. So this is a diagram of the inner ear. On the left of your screen, you'll see the outer ear, followed by the middle ear, and then those purple structures on the right side of the ear is essentially your balance organs. The snail-shaped structure is the cochlea, which is responsible for hearing, and then you'll see those circular type pieces above the cochlea, which we call the semicircular canals. So how do these semicircular canals and the vestibular sensory organs work? Well, on each side of your ear, so on the left and the right, you have three semicircular canals. And they are essentially responsible for detecting angular movement or rotation and velocity. So if you were nodding yes or no, it's these semicircular canals that will detect that kind of movement. Now, these canals are filled with fluid, and there are lots of little hairs that stick up within those canals. So when you move the head, the fluid moves, and they push against the little hairs. And those hairs are like little motion sensors. So they sense the movement and then send a message up to the brain, telling the brain how you're moving, how fast you're moving, etc. And then the brain can do what it needs to do with that information to keep you stable and balanced. There are also some other vestibular organs, which we call otoliths, and they are made up of two structures called your utricle and sacral. And what they are responsible for is detecting linear acceleration and static tilt of the head. So if you were taking off in an aeroplane, it is the otoliths that sense that acceleration as well as the tilt of the aeroplane. And together, these organs help to orientate the head in space, detect motion to allow for positional adjustments of the eyes, head, and posture to maintain vision and balance. So how do you know if you need to see a vestibular physiotherapist? I've put this slide up because this is a question I often get asked. So any of the questions that are answered in red could suggest that it would be useful to see a vestibular physiotherapist. So you need to ask yourself, do you get dizzy? And is it a spinning sensation? Is it a fainting feeling? So if it's more of a fainting feeling like you're going to pass out, that potentially could suggest something more cardiac or heart related as opposed to vestibular related. Do you have a sense of disequilibrium or imbalance? And then thinking about how long does it last for? This is often a question that a vestibular physiotherapist will ask you because it can be quite diagnostic depending on how long these feelings last for. Do you feel off balance? And then thinking about what makes it worse. So often movement makes things worse, or busy environments, or walking around in the dark. And all of those things should be investigated. Because as we know, there are many, many causes of vestibular problems or dizziness in people. There can be things related to the brain that cause dizziness. There can be things related to the inner ear. There can be cardiovascular things. And then there can be other things like psychological conditions or certain medications. So if you were to go to a vestibular physio, what are they going to ask you, or what are they going to assess? Well, first and foremost, they're going to ask a very detailed history. They might look at things like heart rate, blood pressure, strength, sensation, coordination, speech, and potentially have a look at your neck as well, because some neck issues can sometimes cause some dizziness. They're then going to have a very good look at your eyes. Positional testing. This is where we look for conditions like Bppv, which I'll talk about in a minute. And then looking at things like a head impulse test or a dynamic visual acuity test. These are all tests that look at something called your vestibular ocular reflex. This is a reflex that allows the eyes to stay still while the head is moving. It's a very important reflex and can often be affected in certain conditions like Meniere's disease. They might look at your motion sensitivity and of course your balance and your gait or your walking. So what I'm going to do now is just talk a little bit about vestibular migraine, because I know a lot of you are very interested in this. So what is a vestibular migraine? Well, essentially it's a disorder where people with migraine headaches develop vestibular symptoms such as dizziness, vertigo, nausea, and imbalance. Now, symptoms can occur at the same time or between headache episodes. So you don't have to have a headache at the same time as your vestibular symptoms to be diagnosed with vestibular migraine. And it's generally considered a central disorder, which means it's more driven by the brain as opposed to the inner ear. How common is it? Well, it's actually very common. It's considered the most common cause of recurrent spontaneous vertigo attacks. So it's very, very common. It's more common than Meniere's disease. Bppv would be the most common positional type of vertigo, but migraine is certainly a pretty close second. It has a lifetime prevalence of somewhere between 1 to 2.7%, so fairly high, I suppose. And it accounts for 7% of patients seen in dizzy clinics and 9% of people seen in migraine-specific clinics, and that came out of America, that statistic. It is more common in women, so anywhere from 1.5 to 5 times more likely in women, depending on what research you read. And vestibular migraine is actually the most common cause of vertigo and dizziness in children. So what causes it? It is not fully understood. So like a standard migraine, it is not fully understood. It's likely a disturbance in the way the brain processes information about sensation, pain, and vestibular information. It's thought to be a combination of vascular and neural processes. So it's not solely a vascular process. There are certain neural processes thought to take place as well. And there is also evidence of an inherited form of vestibular migraine. So how is somebody diagnosed with a vestibular migraine? There is some diagnostic criteria that we generally follow. Certain aspects of it can be a little controversial, particularly around how long things last for. So for someone to be diagnosed with a vestibular migraine, they must have at least 5 episodes fulfilling criteria C and D that I'll talk through in a minute. The person must have a current or past history of migraine with or without aura. And vestibular symptoms of moderate to severe intensity lasting anywhere from 5 minutes to 72 hours. Although there are reports of the symptoms lasting shorter than 5 minutes and also longer than 72 hours. Vestibular symptoms could include anything such as dizziness, imbalance, nausea, vertigo, feeling lightheaded, swimming or rocking sensations, motion sickness, light sensitivity, sound sensitivity. Another part of the diagnostic criteria is that at least 50% of the episodes are associated with at least one of the following 3 migrainous features. So the person must have a headache with at least 2 of the following 4 characteristics. So unilateral location, meaning one-sided, of pulsating quality, of moderate to severe intensity, and or aggravated by physical activity. The person is often light and sound sensitive, so photo and phonophobia, and they may have a visual aura. And finally, it is not better accounted for by another diagnosis or another vestibular disorder. So this is a condition that is diagnosed by exclusion. So other things have to be ruled out first before we get to this decision or this diagnosis. What are the symptoms? So they can be very variable, and this was what can make it tricky to diagnose and also manage. So some patients will never have a headache at the same time as their vestibular symptoms. And symptoms can mimic other vestibular problems, which is why other things have to be excluded first. During times that the person is not having any symptoms or they're not having a vestibular migraine, vestibular testing is actually often normal. There can be a migraine headache, which is usually severe, throbbing type headache and usually one-sided. Often the people will describe nausea and vomiting. As I mentioned before, sensitivity to light, smell and noise, and about 50% of migraine sufferers will describe that. There's a very strong association with motion sickness. So a large percentage of patients with migraine will have motion sensitivity. A lot of people will describe vertigo. So that's that true feeling like you're spinning or the world around you is spinning. So around 57% of vestibular migraine sufferers will describe vertigo. And that could be vertigo that lasts for minutes or hours. It could be spontaneous, which means it just happens out of the blue, even if you're sitting still. Or it could be positional, which means it's triggered by changes in head position. Unsteadiness is common, about 91% of patients, and balance problems. People are often very sensitive to visual stimulation, so busy screens, busy environments like shopping malls where there's bright lights. People often have neck pain and spasms, and sometimes that can be just through bracing, and sometimes that can also contribute to triggering migraines. People might describe visual distortion, even mental confusion and feeling a bit disorientated at times. More rarely, but can occur as dysarthria, so speech problems, or even some temporary paresis, so paralysis of the extremities. Hearing changes can occur. However, in a vestibular migraine, it's usually bilateral and usually quite transient. So it's only usually more mildly affected. Now, what can we do for treatment of vestibular migraine? And often this is a multidiscipline approach that we need to take for vestibular migraine. So quite commonly, a herbal supplement called Migraine Care, which is by Bioceuticals, is often recommended to patients by the neurologists who specialise in this area as a first port of call, because for some clients this really helps. People are usually asked to take it for a couple of months because it takes a little while for it to build up in the system and take full effect. So that's one sort of herbal remedy that can help some people. There, of course, then are your stronger medications, so preventative type medications, things like Effexor or abortive medications. So once you're actually having a migraine, things like aspirin. Obviously, this is best managed by a GP or a neurologist. I am no doctor, so I certainly don't get involved in the medication side of things. But it is often helpful to start these medications prior to beginning vestibular rehabilitation, because it often allows for better tolerance to the exercise regime without exacerbating symptoms. Now, it's not essential that people start these, but it is often quite helpful. And then there's vestibular rehab, which is also a very important part in patients experiencing vestibular migraines. And really the goals of this is to reduce symptoms and improve the use of the vestibular system for balance and mobility. Because people who have vestibular migraine often have something called central vestibular dysfunction. So essentially what happens in this situation is the ability to tolerate movement is reliant on that information from your inner ear and your eyes matching up to tell your brain what is happening. Now, in central vestibular disorders, of which vestibular migraine is considered one of those, or following damage to the brain, many people will experience problems with the messages going to or from these systems in the brain. And this often results in motion sensitivity and nausea. And the natural response for a lot of people at this point is to avoid movement because it makes them feel worse. However, this is actually the worst thing you can do. So what we work towards doing is something called habituation exercises, which I'll talk about in a minute. And these are graduated and progressed at a level that people can cope with. Vestibular balance exercises are also an important part, as well as a graduated walking program and functional exercises. So always taking it back to the goals of what the person wants to do. So habituation exercises are based on the theory of repeated exposure to an unpleasant signal will gradually reduce symptoms. So essentially, to gain improvements, the system must be challenged. So what your vestibular therapist will do is choose a couple of movements that bring on moderate symptoms. So we're not going for the severe symptoms. We want to kind of get, maybe a 3 out of 5 if we think is 5 being the worst you could possibly feel. So aiming for that middle ground. And we would choose some movements that bring on a moderate amount of symptoms and get you to perform those regularly. Over time, those symptoms will reduce. And then what we will do is continue to progress the exercise by either making it faster, doing different postures, perhaps adding in more functional components, adding cognitive loading, changing the visual environment. What's important with these exercises is that they have to be done regularly. And depending on how symptomatic you are, your therapist may decide that once or twice a day is enough for you to begin with. However, the goal is to build them up to 3 times a day, providing you're coping with them. Balance exercises, as I said, are also very important. And your vestibular therapist will make these exercises very individualized and might do things with your eyes closed or on unstable surfaces, bringing in different visual challenges, different speeds, different surfaces, making them much more dynamic. We know the vestibular system is a dynamic system, so it likes movement. Therefore, we need to do exercises that target this. And what's the evidence like? So there was one study that was done in 2013 where they took 36 patients, 6 had some kind of vestibular impairment and 20 had vestibular migraine. They had only a total of 5 sessions. So they had an appointment initially, then at 2, 5 and 9 weeks later, and then 6 months later. The treatment involved things like your habituation exercises I've just talked about, some gaze stability type exercises, balance exercises, gait or mobility exercises as well. And they had to do these 15 minutes 3 times a day for the first 9 weeks. And what they found was that there were significant improvements on all measures, so your objective and subjective measures. Objective meaning what you actually take on a particular outcome measure, and subjective is more or less what the patient is telling you at 9 weeks and at 6 months for both groups. And the same degree of improvement was observed regardless of what medication regime they were on. So that is certainly quite encouraging that it really can help people with vestibular migraine. What other treatments can be useful for people with vestibular migraine? Certainly reducing anxiety and stress. So anxiety and stress for some people can trigger vestibular migraines. So keeping that at bay can be very helpful. And for some people that could be, you know, through sessions with a psychologist, or it could be self-managed through sort of self-help forums, etc. Identifying and avoiding diet or other triggers. So there are some sort of known triggers in vestibular migraine, and I'll just show you after this a few slides of some of the common triggers. Not everybody has triggers or food triggers, and certainly not everybody has all of them. But if you can identify certain triggers, then it's much easier to manage. And then lifestyle modifications, so making sure you get regular sleep, regular exercise, and regular meal patterns. The body and the brain love regularity. So certain food triggers in people with vestibular migraine are a lot of the good stuff. So a lot of your good cheeses. As you can see here, I'll let you take a few moments to have a look, but smoked, cured, processed meats, food prepared with meat tenderizers, onions, olives, pickles, alcohol, especially red wine, port, sherry, scotch, gin and bourbon, chocolate. As I said, all the good things in life. So as I said, also, not everybody will have all of these triggers. So it's about identifying which, if any of these, you have. For other people, triggers might include hormone fluctuations or barometric pressure variations, sleep disturbance, stress, and certain medications. Okay. I'm just going to talk a little bit, very briefly, about Meniere's disease, because I assume quite a lot of you know a bit about this already. But interestingly, people with Meniere's disease are reported to be twice as likely to also get vestibular migraine. So it is not uncommon at all for people with Meniere's disease to also have vestibular migraine. There's a strong association between the two. And the most reliable differentiating feature is that you get a low frequency hearing loss in Meniere's disease, which you generally don't get in vestibular migraine because there is a lot of overlap between the two conditions. And for that reason, it's been proposed or considered that both of these conditions could be part or could have a common genetic basis. So again, diagnostic criteria for Meniere's disease. The person must have 2 or more attacks of spontaneous vertigo. So vertigo, spinning type sensations that come on out of the blue, lasting for anywhere from 20 minutes up to 12 hours. And they must also have documented low to mid-frequency hearing loss, defining the affected ear on at least one occasion before, during, or after the vertigo attack. Diagnostically, Meniere's patients have fluctuating oral or hearing symptoms, so tinnitus, fullness in the affected ear. And again, it's not better accounted for by another vestibular diagnosis. Okay, so you can see when you compare this to vestibular migraine, the biggest differentiating feature is the hearing changes. This table here just shows you some of the kind of key pointers to be thinking about if we're thinking, is it VM or vestibular migraine or MD, Meniere's disease? So tinnitus is not that common in vestibular migraine, but if it is present, it's more likely to be high-pitched, whereas Meniere's disease, it's probably low-pitched. Hearing loss is rare in vestibular migraine. As I said, if you do get a bit of hearing loss in the vestibular migraine, it's usually transient and certainly not significantly severe. Whereas hearing loss, we know in Meniere's disease, is very common. Phonophobia and photophobia, so light, sound sensitivity, is common in vestibular migraine, and not so common in Meniere's disease. Migraine, a short nap often helps, whereas in Meniere's disease it often doesn't. Severe motion sickness is more common in migraine than it is Meniere's as well. Now, people with Meniere's disease, because it often causes a progressive loss of vestibular function with each repeated attack, this causes something called peripheral vestibular hypofunction, which essentially means the vestibular system is not working at 100% because of the damage to the vestibular or inner ear balance system. Now, damage can be complete or partial, and it can be unilateral or bilateral, which means one-sided or both sides. Essentially, the sensory cells in the vestibular organs are damaged and therefore can't send signals correctly to the brain. And the brain gets confused by that. Therefore, movement of your head or body results in vertigo, visual disturbance, and a loss of balance. So common symptoms in vestibular hypofunction, which remember Meniere's disease is one of the conditions that can cause this. So if only one side is damaged, at the initial onset of it, or during a repeated episode, the person will get this initial vertigo, spinning sensation, nausea, loss of balance. And that might then be followed by dizziness and visual blurring on rapid head movement. So if you turn your head quickly, you might just notice a split second where your vision blurs or you feel dizzy. People often feel off balance, lightheaded, disorientated, or spacey, and that can last for a while. If both sides are damaged, so if you're somebody who suffers from perhaps bilateral Meniere's disease on both sides, generally you don't experience necessarily dizziness or vertigo if it's a complete loss on both sides. But what you might experience here is something called oscillopsia, and this is where you get an apparent movement of a still environment. So it would be like watching a bouncy sort of screen on your computer where things are just constantly bouncing up and down. And that's because of damage to something called your vestibular ocular reflex. Might be generally feeling lightheaded, you might have severe walking impairment and severe problems with your balance. So what do we do for people who have vestibular hypofunction? Well, the aims of treatment here is to improve visual stability, because often vestibular hypofunction results in damage to that vestibular ocular reflex. So that's a reflex that allows your eyes to stay still while your head moves quickly. So we try to improve visual stability through targeted exercises. We also try to reduce symptoms so people are not feeling so dizzy all the time. Improving balance and really maximizing balance to the best of our ability. Maximizing mobility and function, reducing falls risk if that's an issue, and of course providing the person with lots of education about what's going on. The key point here, yet again, is that we must move and challenge the brain and the inner ear system to get better. Okay, so if you're feeling really dizzy and you stop moving and you stop moving your head and you don't want to look around, that will lead to sort of more chronic problems and often make things worse. If it's an acute, certain conditions such as vestibular neuritises, someone might be put on vestibular suppressants initially, like your Stemetil, but actually we want those patients in that situation to avoid using vestibular suppressants once we start rehabilitation. Okay, I also just wanted to touch briefly on Bppv. And the reason I wanted to draw this to your attention is Bppv is one of the most common causes of dizziness or vertigo in people. So it's the most common cause of dizziness secondary to medications. So very, very common. And there is a strong association with Bppv and vestibular migraine. So people who have vestibular migraine are more likely to also have episodes of Bppv. Now, not everybody with vestibular migraine will have Bppv, but there certainly are a handful of people who do. So Bppv stands for benign paroxysmal positional vertigo. Benign means it's not dangerous or likely to cause any lasting effect. It's just a jolly nuisance. It's rapid, it's short, and you get these frequent episodes. It is always triggered by changes in head position. So typically, if people are bending down, rolling over in bed, lying in bed, getting up from bed, it may trigger Bppv symptoms. And people will get vertigo, that abnormal sensation of movement. So the symptoms or the characteristics of Bppv is that the vertigo is usually always brief. So the person might move into a certain position, they'll feel like things are spinning around. It will settle fairly quickly within a few seconds, and then it kind of settles. It may, however, be accompanied by other symptoms which can last a lot longer, so nausea, vomiting, imbalance. You never get hearing loss or tinnitus with Bppv, and as I said before, it is always triggered by changes in head position in respect to gravity. So what is Bppv? Well, it's where you get calcium carbonate crystals or particles, which we call otoconia, that fall into one or more of those semicircular canals, and they're not supposed to be there. So now what happens is when the person moves their head, not only does that fluid move in the canal that you remember me talking about at the beginning and stimulate the hair cells, but also those calcium carbonate crystals also push against the little hair cells. And what that does is it overstimulates the hair cells. So it sends a much stronger signal up to the brain, telling the brain that you're moving more than you actually are on that side. And the brain gets very confused by that because it doesn't make sense with what the rest of the body is telling it. The brain is very clever and it tries to figure it out. So it thinks something is not right. The affected area is telling me one thing, yet your vision, your muscles in your joints and your other area are telling me something completely different. And so the brain will try to reorganize itself or reboot itself. And so what it does is it initiates or brings on this reflex eye movement that we call nystagmus, where your eyes actually then start to flicker. And think of that as the brain's way of trying to reboot itself. But as a result, you feel like you're spinning because your eyes are actually moving. The good news about Bppv is it's very treatable. This is not a condition you have to live with at all. We can do things called Canalith repositioning maneuvers, which is essentially a fancy way of saying we move your head in a specific way to move those calcium carbonate crystals out of the semicircular canal. So think of those little pinball machines with the little ball bearing and you're trying to maneuver it out through the little hole. That's essentially what we're trying to do. But the treatment has to be specific to the affected canal. You remember that there are 3 of those semicircular canals on each side. And the treatment is different depending what canal is affected And it also depends on the type of Bppv. So there are different forms of Bppv. So some people can go on and Google and they might find something called an Epley maneuver, which some of you may have heard of and tried. That's very specific to the posterior canal, and something called a canalithitis form of Bppv. However, that's not going to treat Bppv if it's in a different canal. So that's just something to be aware of. If you're trying that and it's not working, it's probably why. So that's all I really had to say about Bppv, but good to draw it to your attention because of its common link with vestibular migraine. Okay, so I really wanted to open the floor up now for questions, but just wanted to end, I suppose, by saying that life is like riding a bicycle. To keep your balance, you must keep moving. And I think that's really, really important here, because often what we find is people with vestibular problems really stop moving or stop moving their head, and that's actually the worst thing you can do in a lot of cases. Okay, so